I'm happy to introduce Ari Naiman. I think many of you have heard Ari speak before. He's the president and co-founder of the Autistic He was, but he's going to tell you what he's doing now. And he's here to talk to us about quality in home and community-based services to support successful community living. Ari, thank you.
Thank you so much. It's an honor to be back here at the Update in DD conference. I'm sure at some point they'll have the timer continue to move, but in the meantime, I'll just keep track from my phone. My name is Ari Naiman. Many of you know me from some of my past roles. From 2006 to 2016, I ran the Autistic Self-Advocacy Network, national advocacy organization run by and for autistic people, speaking for ourselves. From 2010 to 2015, I was one of President Obama's appointees to the National Council on Disability. I currently direct a project called My Support, which I'll talk a little bit about here, which focuses on giving people with disabilities and families more tools to find workers that share their values. But I'm really pleased to have the opportunity to talk with you on the topic of home and community-based service quality. There has been a tremendous amount of change in our field, in the world of developmental disability, over the course of the last 10 to 20 years. And that change has largely been for the purpose of promoting more self-determined lives, more quality of life, more choice and control in people's outcomes. But one of the unfortunate challenges that we have is that it's relatively rare that we go to a service provider and we pick up their brochure and they say, we are against self-determination, choice and control, and for coercion, restraint, and, you know, generally speaking, if you look at the marketing in our field, from the service providers to the health plans in some states to any number of other entities, folks say they're for good things and they're against bad things. And the problem that we have is, historically, we've had very few tools to evaluate whether that is, in any reasonable sense, true. In the context of quality measures, there's a long history of states using healthcare quality measures, usually to hold managed care plans accountable for particular kinds of outcomes, but most of the quality measures that have been used historically have focused on very traditional medical care outcomes. They may evaluate the degree to which folks were in an emergency room in the last 12 months, or the prevalence of diabetes, or the speed with which particular forms of medical treatments are used within a certain time frame upon entering an emergency room or a doctor's office. But as we've started to see more of an emphasis on quality improvement in long-term services and supports and in home and community-based services, we've started to see an emphasis on quality around measuring outcomes in the home and community-based service world. I recently completed, along with Steve Kay from the University of California, San Francisco, a 2-year term of service on the National Quality Forum's work group on home and community-based services quality measures. And what I'm going to be doing here is I'm going to be going through a variety of quality measures that states are using, sometimes to evaluate the performance of managed care plans within states that have adopted managed care frameworks for their disability and aging services, sometimes to evaluate the performance of individual service providers, and sometimes to evaluate themselves and to really ask and challenge themselves what we can do to improve the quality of services we may be administering at the state or regional center level. So, with that old maxim of "in God we trust, everyone else please bring data," Let's jump right into it. One of the first domains that the NQF work group on HCBS quality looked at was service delivery and effectiveness. And I want to highlight 4 quality measures used in actual state managed care contracts or quality improvement systems that look to measure quality in disability services. The first, the number of service hours delivered minus the number of service hours approved, is used by the state of Delaware's Managed Long-Term Services and Support System. The second, the percent of people with disabilities responding yes to do the services you receive meet your needs and goals, is from the National Core Indicators Project, a quality improvement system historically used only for people with developmental disabilities, and it recently expanded to the aging and physical disability world. The proportion of individualized care plans with goals unmet comes from the New York Managed Care System. And the fourth, which also relates to the number of late missed visits and talks about the reasons for them, comes from Tennessee's system. And one of the things that I think is really important to highlight here, and we're going to be seeing this fairly consistently across each of the domains of quality measurement that are being utilized by states and by service providers for different purposes, is that these are very different kinds of measures, and they have very different strengths and flaws. Generally speaking, states will seek to incorporate at least some measures that can be derived specifically from utilization data. So the number of service hours delivered minus the number of service hours approved, and then complement those measures with measures that are derived from survey data, like the National Core Indicators Project. NCI surveys large numbers of people with disabilities, family members, and providers for the purposes of determining whether or not someone has choice, control, autonomy, and other dimensions of quality in their life. The reason why, usually in well-designed systems, states will couple data from quality measures from utilization data with quality measures from survey data, is that generally speaking, it's possible to see really significant flaws in both. We all know that survey data is often highly subjective. People are often not aware of the degree to which other options may exist. So to talk to someone about whether or not they feel they're included in the community, if all they've ever been exposed to is a group home, and being included in the community to them means that somebody takes them to the mall once a week, is often not the most useful metric, because there isn't really any determination that there's been an informed process by which folks are deriving their answer to that question. At the same time, data that comes from just strict analysis of the kinds of services that people receive is often at times misleading. For example, if we look at the Delaware statistic, the number of service hours delivered minus the number of service hours approved, one problem with looking at that statistic as the sole measure of quality is that a particular health plan may be more likely to approve more service hours than somebody needs as a means of preparing for crisis situations in which a pre-authorization requirement for adding more service may significantly delay access to necessary support. And so if all we're looking at is a ratio of services delivered as compared to services authorized, then we also have the potential to really run into issues associated with how we're delivering services, warping how we're measuring quality in services. One of the other and more tricky components when it comes to measuring quality, and this was a really heavy emphasis in the discussion of HCBS quality measures on the NQF panel, is how we look at quality specifically within the context of planning around service provision, as distinct from quality around how service provision is delivered. We generally know that within the context of home and community-based services, choice and control over what you're getting matters just as much as whether or not and what particular form of service provision you're receiving. And so a growing number of quality measures are looking at the degree to which people are reporting they have the right to control what goes in their service plan, the frequency with which their services can be reassessed, the degree to which individuals have easy access to service coordinators and can clearly communicate with them over time. Some states have incorporated measures like the percentage of service coordinators who have been trained in self-directed services and can then offer that to an individual as an option. One of the challenges that comes up when trying to measure quality within the process of determining how services are delivered is that often an emphasis on the process can detract from an emphasis on the outcomes. So we have some states that have chosen to measure the percentage of individuals who choose to self-direct their service as a metric in quality outcomes in home and community-based services. Other states that have chosen to measure the percentage of individuals who end up in home and community-based services or who end up in integrated employment. And then we have other states that have chosen to measure the degree to which those options are offered as an alternative within the service planning process. And the challenge that we really run into there is if the emphasis is solely on the planning process and not on the broader focus of what ends up being delivered, we may have a situation where a service coordinator receives training in self-direction or receives training on integrated employment, but that training does not really translate into concrete outcomes in the field afterwards. The National Core Indicators Project and other similar surveys like the Council on Quality Leadership's Personal Outcomes Measure Survey and others have long looked at the question of choice and control over people's lives. And this is something that's highly relevant within the context of the home and community-based settings rule. And many states are now asking themselves within the context of their settings transition plans. Every state must deliver to the federal government, and each state has, but they're periodically revising it, a settings transition plan indicating how they will comply with the home and community-based settings rule by 2019. States are now asking themselves, how can I measure compliance with requirements of the settings transition rule, like facilitating choice in who provides services, or optimizing autonomy, or allowing for privacy, dignity, and respect. Often very broad-based aspirational concepts that in order to show compliance with new federal requirements must be operationalized at a very practical level. NCI and other quality measures often look to survey instruments around questions of quality, like can you see your friends when you want to? Did you pick who you live with? Did you pick where you live? Did you get to pick who your case manager is, or can you switch case managers if you have a problem with them? Can you pick who your roommates are? As a way of evaluating the degree to which their state or a health plan or potentially in the future a regional center is delivering compliance with the settings rule or other program goals in home and community-based services. Self-direction is often used as a metric for this, in part because it fits one of the basic requirements for a really good quality measure, and that's significant variation across the country in outcomes. So this chart from the National Resource Center on Participant-Directed Services shows the proportion of people with disabilities who are self-directing as compared to the number of individuals on SSI within that given state. And one of the things you see is that California at the top is dramatically more likely to see self-direction as an outcome within the state than the rest of the country. So there's significant variation. In fact, about half of people with disabilities who self-direct live in California, largely as a function of the IHSS program. And so self-direction often serves as a very good indicator for evaluating home and community-based services quality. And if we look at different state self-directed programs, you have some that have similar level of intensity: California, Oregon and Washington, New York, Massachusetts, others, Texas, others that are really just getting stood up. And that's something that's helpful, because a quality measure doesn't do very much for us if it's a survey in which consistently across every state, 95% of people say they're happy with their services. So, again, this is, I think, a powerful argument for coupling multiple quality measures and looking prior to determining a quality measure for use in a particular purpose, that there is variation in outcome. Within the context of both the settings rule and broader program design goals in home and community-based services, states are beginning to look very closely at community inclusion and measures of community inclusion. And usually what states will do is they will tie specific financial outcomes to metrics of community inclusion in home and community-based services and in long-term services and supports as a whole. So many of the states with the longest running managed care systems for long-term services and supports will reward health plans that increase the number of individuals who transition from an ICF or a nursing home in a given year from the expected rate of transition based on past trends. So if you're increasing the speed at which individuals leave institutional settings, then a health plan is more likely to qualify for additional bonus payments. Often, states will withhold a certain percentage of a capitated payment, between 3 to 5% is common, and basically give multiple health plans competing within a state an opportunity to win that pot of funds representing 3 to 5% of capitated payments within the state, almost from the other health plans in the event that they show better outcomes than them. And so the idea here is to reflect, for rebalancing from institutional to community-based settings, an emphasis on competition between health plans as to who can accelerate that process. What's relatively new, and one of the things looked at by the NQF panel, is measuring quality within the context of home and community-based services themselves. So New York, which has recently embarked on a relatively aggressive project of promoting supported employment, has incorporated within their managed long-term services and supports proposal a indicator on the proportion of individuals in sheltered workshops who transition to integrated community-based employment. And in the future, health plans in New York may be in a position to see additional reimbursement in the event that they see more aggressive integrated employment outcomes. Hawaii, in which transportation is a very significant issue, decided to prioritize a survey instrument tool around HCBS, individuals receiving HCBS who reported they had adequate transportation when they wanted to go somewhere. New York, again, has emphasized integrated employment. So we're relatively new in around quality measures that are focusing on transitions within one kind of HCBS to another kind. The next frontier there is really to start to look at how we measure HCBS service quality and transitions within residential placements. States may soon be adopting quality measures that evaluate the percentage of people who transition from group homes to supported living or shared living settings in a very similar way that we've seen in the past. States evaluate the percentage of people who are transitioning from nursing homes and ICFs. One of the other really important concepts that has been emphasized in an emerging way in quality measurement is the idea that services are not just directed towards the individual. Particularly for people with developmental disabilities, the idea of having access to natural support and family support is absolutely critical. So quality measures that are looking at the degree to which parents, family members, other caregivers can report that they are able to maintain their health in light of their caregiving obligations, can report that they've been receiving clear instructions around paramedical tasks that they may have associated with the delivery of services that a family member may be expected to take on. Obviously, we want a quality measure that's going to be telling us if a family member is expected to perform substantial medical tasks but isn't being given any kind of instruction or support as to how to do that. As well as other measures that are looking at the idea that the health of the family relationship is an important component in the quality of service provision. I want to emphasize why this matters, especially as we start to see the shift towards managed care. Typically, and there's variation, and certainly California is one of the significant sources of the variation here as a state that has generally not put its developmental disability services in managed care, but in most of the country, a managed care contract lasts between 3 to 5 years. So a state will contract with a health plan, usually one of the large national health plans, sometimes local nonprofits, and they will say, you have control over, you have responsibility over this population, with some shifts in open enrollment periods between competing health plans over the next 3 to 5 years. And if you are that health plan, one of the things you very quickly realize is that families who have a commitment to supporting their relative with a disability can probably hold on, in a lot of cases, for 3 to 5 years, even with a relatively poor quality of service provision. And so if all you're counting on for a health plan to be incentivized to deliver high-quality services is the fear that someone's going to end up in an ICF or a more expensive placement in the event that those services are not delivered, oftentimes health plans will operate under the assumption that's 6 years out, that's 7 or 10 or 15 years out. We don't need to concern ourselves with that. And so one of the purposes of measuring dimensions of quality, which maybe down the line are going to correlate to dimensions of cost, is so that you can say, health plan, you are financially on the hook for meeting these measures that will tell us if the families who are providing unpaid supports to people with disabilities are barely holding on, even if that family is going to end up holding on past the term of your contract. And that's a very consistent theme in other metrics as well. We generally see that supported employment is more cost-effective to payers than sheltered workshop services over a long enough time frame. So if health plans are not held accountable for delivering integrated employment outcomes within that 3 to 5 year time frame with which they have contracts, then they may say, all right, this is an area of ROI that's realized 7 to 10 years out. We don't have to focus on that. So again, one of the overall goals in caregiver support and integrated employment and in other areas is to make sure that health plans and others who have responsibility, often on a short-term basis, in evaluating and delivering services to people with disabilities, are responsible and have a financial incentive to promote quality, even if the consequences aren't going to come for years later. We're short on time, so I'm going to jump forward a little bit, but we have other measures that are available in your program books around workforce, human and legal rights, equity, and holistic health and functioning. I do want to highlight a couple of things within this context. Equity is an area in which quality measurement is often still relatively new. States have very different ideas or different priorities around where their equity considerations are in home and community-based services. If you are a very diverse state, or to talk in the California context, a very diverse regional center, you may have particular priorities around equity in the delivery and outcome of services across linguistic and racial and ethnic minorities. Many of you are very familiar with the racial disparities in the California Regional Center System's delivery of purchase of service funds. And that's a significant area in which equity is being measured, and hopefully in the future that will lead to more equitable outcomes. There's also been a focus on how we can look at health within the context of how health intersects with long-term services and supports. Because quality measures have mostly come about when states have adopted managed care systems, and most state managed care systems in the 1990s and early aughts emphasized non-disabled adults and children. Usually quality measures focused, when they looked at medical outcomes, just on medical outcomes in the context of doctors, primary and specialty doctors' care, hospital services, and other traditional acute care outcomes. One of the things that's being looked at now is how we can start to focus on outcomes that specifically look at individuals who are receiving home and community-based services and their special health care needs. So I want to touch on a couple of just closing principles that I think are important for considering what quality measures may be doing for us over the course of the next 5 to 10 years. One of the most important things that quality measures do, in addition to holding health plans, service providers, regional centers accountable, is they give very clear instructions to the field about where innovation should be prioritized. I mentioned that in my new role, I manage a project called MySupport, which is an online provider directory that makes it easy for people with disabilities to find workers that share their values, answering match questions around personality, values, support needs, and other components to make it easy for folks to find workers. One of the reasons we adopted we entered into the process of developing the MySupport platform is it had become very clear that states and people with disabilities advocating to states about what kinds of quality should be promoted in the future were heavily emphasizing self-direction as an outcome that should be encouraged. In California, that's taken the role of the May It Come Swiftly and Within Our Days upcoming self-determination program. In other states, that's taken the role of health plans being required to increase the percentage of individuals with disabilities and seniors who are self-directing their own services on a year-on-year basis. But one of the things we say when we embark on quality measurement is we want our system to move in this particular direction. And in doing so, we tell technology providers, service providers, advocates, and other stakeholders, this can be an area of common focus and common cause over the course of the coming years. In the future, one of the biggest areas in which quality measurement has not yet focused, but we're starting to see an emphasis around, is quality measurement at the provider level. There's a long track record of using quality measures to hold a health plan or a state accountable for outcomes across the broad scope of services, the broad scope of providers within a system. What we've started to see is the introduction of reimbursement strategies to particular providers that reward them for delivering better outcomes. One of the biggest areas this has been happening is in employment service provision. A number of states have adopted employment service provision reimbursement models where a service provider is no longer reimbursed solely for the number of hours of job coaching they provide, but instead can be reimbursed for the number of hours the people they are supporting are working. That's a very significant shift. It means that service providers don't realize a loss if they're doing better at encouraging natural supports, at starting to fade out their role over time. We're beginning to think about how we can apply that to residential service provision as well, as we look to encourage the possibility for residential service providers to help facilitate natural supports and community relationships in a way that will mean that provider is rewarded for what we want to see. People getting support, people getting help from their broader community instead of solely through paid service provision. And we've also started to see opportunities for providers to take on some degree of risk within the service provision system. At the federal level, and there are some very deep concerns that the implementation of this may not keep to our values around community inclusion. There's now a proposal to introduce the PACE model, in which a service provider becomes fully responsible for the broad scope of somebody's LTSS and medical services for non-elderly people with disabilities. But the overall concept here is we've, for a long time, been emphasizing measuring quality in how we hold our states accountable and how we hold our health plans accountable. And in the future, quality measurement can be a tool we use to go to providers and say, we expect you to deliver the kinds of self-determined, included lives that we want for our community. And we're going to make sure that in the ways we pay you and in the ways we compensate you, you have the opportunity to benefit from that. I'm going to stop here, and hopefully we've left enough time for the panel. Thank you all very much for your time.